Exogenous eczema. Exogenous eczema is caused by factors that are external to the body, and it includes contact and photodermatitis. Contact dermatitis divided into irritants and allergens, and photodermatitis as abnormal skin reaction to UV rays. Contact dermatitis, which can be either allergic or irritants, and the irritants contact dermatitis account for 80% of all contact dermatitis. Common contact allergens include nickels, potassium dichromate, which is the chemical used to tan leather, perfume that contain myriaxylum perrulae. Distribution of the skin changes is often helpful in identifying the underlying cause. Hand dermatitis can result from glove allergies, which is rubber and latex, and the itchy rash on the foot may indicate allergy to footwear, which is potassium dichromate. The classic picture of contact dermatitis is a well-demarcated erythematous, fascicular, scaly patch or plaque with well-defined margins corresponding to the area of contact. The characteristics of allergic dermatitis are as follows. First, it must have a previous exposure to the substance concerned. There will be 48 to 96 hours between contact and development of changes in the skin. And acute allergic reactions tends to be intensely itchy and results in erythema, edema, and vesicles. The more chronic lesions are often lesionified, which has features of skin thickening, hyperpigmentation, and exaggerated skin lines. Pathogenesis of allergic contact dermatitis is a delayed type hypersensitivity reaction. Specific antigens, which usually proteins, will penetrate the epidermis and combine with a protein mediator and will be picked up by a Langerhans cells. This causes T lymphocytes in the regional lymph nodes to become sensitized to the antigen, which could mean that the lymphocyte has become active. On subsequent exposure to the antigen, the allergic reactions occurs because of the accumulations of sensitized T lymphocyte at the sites of the antigen, with a resultant inflammatory response. Irritant contact dermatitis (ICD) is a cutaneous inflammatory disorder resulting from activations of the innate immune system by direct cytotoxic effect of chemical and physical agents. The dermatitis occurs soon after the exposure, and there is no predictable time interval between contact and the appearance of the rashes. The irritants can be divided into physical irritants, which include air conditioning, prosthetic limb, personal protective equipment, and repetitive mechanical trauma. Chemical irritants include detergents, solvents, and acids. ICD is the most common form of occupational skin disease, estimated to be constitute between 70% and 80% of all occupational skin disorders, most often affecting those who involve in wet work such as cleaner, hairdresser, food handler, and healthcare personnel. Pathogenesis is involved activations of the innate immune system, which is the barrier that forms the first-line defense in the immune response. The mechanism involved in the acute and chronic phases of ICD are different. In acute phase, it begins with a penetration of the irritant through the permeability barrier, which is the stratum corneum. Exposure to irritants lead to stratum corneum damage and subsequent skin barrier impairment. When injured, the ability of the stratum corneum to maintain hydration is reduced, leading to increased transepidermal water loss. and this will decrease water content in the skin. This impaired skin barrier will facilitate the entry of the irritants. Irritants penetrate the stratum corneum and directly activate epidermal keratinocyte, mild damage or stress to keratinocytes, and the release of mediators of inflammation with resultant T-cell activation. For the chronic phase, it is hypothesized that chronic phase reaction occur due to repeated exposure to solvent and surfactants that will gradually extract lipids and water-retaining substances from the stratum corneum. The increase in transepidermal water loss is thought to then promote cell proliferation and hyperkeratosis, which is the increased thickness of the stratum corneum, the outer layer of the skin, which will manifest as the chronic eczematoid irritant reaction. Clinical features. Usually in acute, it is due to single severe exposure. Patient will have localized, well-defined redness, papules, swelling, and also blistering. In chronic cases, it is usually due to mild irritants or repetitive cumulative exposure, in which patient will have dryness and also hardening of the skin with time. In reaction to UV rays, certain chemicals and drugs can cause sunburn, an eczema-like reaction, or hive. The reaction may be related to an allergy, or it may be a direct toxic effect from the substance. The examples of substance or circumstances that may trigger one or the other type of reactions include sulfonamides and tetracycline, and also topical antihistamine. Patch test is used to determine the substance that can cause contact dermatitis. The true test, which is approved by US Food and Drug Administration, consists of panels with pre-impregnated allergens currently screened for 36 allergens. These patches will be applied to the back, and the patient is sent home with instruction to keep the back dry. The results will be evaluated at 48 hours and 72 hours. Interpretations of the results. In picture A, show a doubtful reaction, faint macular erythema only. Picture B, show weak positive reactions. Picture D, show strong positive reaction with vesicular erythema, infiltrations and papules. Picture E, show extreme positive reaction with bullous. Picture G show irritant reaction, which is presence of pustule. For patient counseling information, patients should seek immediate medical attention if they have severe allergic reaction such as trouble breathing or swollen tongue or throat. Avoid UV exposure or tanning beds. Avoid getting the panels wet. Avoid physical activity that may reduce the adhesion. And avoid excessive sweating. Treatment is primarily involve identifications of the causative allergens. Exogenous eczema may be transient and cured after identification and avoidance of trigger factors. After identifying the substance, the most important step a physician takes is to educate the patient regarding the names of the allergens and how to avoid them. Once allergens are positively identified, the patient should be given written information on all of these chemicals. The information sheets should contain data regarding the name of the chemicals, the possible synonyms, typical uses for the chemicals, how to avoid exposure, and when appropriate, the substitution. The physician should try to clear the dermatitis with appropriate treatments, for example, emollients, in which it helps to restore barrier function and also reduce itching. For the cleanser, emulsifying ointments or emollient washes are useful soap substitute. Topical steroids is the mainstay of treatment in active eczema. Steroids should be applied once or twice daily to the affected skin only. Systemic therapy is used in severe widespread disease that is not controlled with topical therapy. Occasionally, dermatology specialists may prescribe a rapidly reducing course of oral prednisolone. Immodulators are useful topical preparations to control mild eczema. Occlusion, covering topical therapy with bandages, body suits, and wet wraps, can be helpful in management of chronic eczema. It can help relieve the symptoms of itchiness and keep the emollient creams on the skin and drive topical therapy through the epidermis. Antibiotics are occasionally needed to treat infected eczema. Phototherapy, which is the light treatment with narrowband UVB and psoralen with ultraviolet A, can be highly effective for generalized eczema.